So it's an interesting question. Can pain be all in your head? I'll start that by saying pain is always in your head because it's a perception, and a perception can only be done by the brain. So part of the processing of information to determine is pain, the sensation is pain, is done by the brain. So all pain is in the brain. The question is whether you can have pain that's only in the brain in the absence of any peripheral generator causing that pain. And patients can have pain that's purely psychological or psychosomatic. Maybe they had an old injury, maybe it's a patient that is what's called a somaticizer, that embellishes physical complaints because of a post-experience or post-trauma. Most of the time there is some real, I won't call it real, but there is some identifiable pain generator that's causing the pain. People used to be thought that they were crazy when they had like phantom limb pain. So that's a patient that after having an amputation continues to have pain. So it used to be considered these people were crazy. How can they have pain in their limb when it's not there? How can they feel that? But there is phantom limb sensation and there is phantom limb pain. And where is that felt? Clearly that's not felt in the extremity that's been amputated. That is felt in the brain and only in the brain, but there is a peripheral trigger for that. Other patients that may have had a life experience that was particularly traumatic, post-traumatic stress disorder, abuse, or just some patients just their brains are wired, it seems, where they have difficulty coping with pain. A smaller pain complaint can cause a great deal of symptomatology. So pain is subjective, and if the patient experiences it, it exists for them. What's challenging from a pain management standpoint is how aggressively do you treat something when the sensory input is minimal and most of it is brain amplification. And the response is, everybody is different and every patient in every case is different, but I wouldn't be overly aggressive treating a peripheral symptom that's has fairly minimal sensory input when most of it is the abnormal processing and embellishment and amplification in the brain. And those patients tend to do better with medications that calm down nerve firing, things like anti-seizure drugs, antidepressant drugs. I probably will do something to treat the peripheral localized pain complaint because, again, it's a response to pain. So it may not seem like it's a major condition. There may not be, for example, a lot of degeneration in that area on imaging. But in some patients, it doesn't take a large sensory input or a significant trigger to cause a large pain response. So if you can diminish that trigger, then you can help the patient deal with their pain. But it's usually in conjunction with treating their central nervous system amplification as well.